Yes, am I audible? Good evening.
Yeah, good evening. This is Dr. Mohammed. You audible, Dr. Karodia?
Absolutely. Thank you for joining us.
My afternoon of interest every Saturday.
Yeah.
Join me.
So what is the timing there?
1:30.
1:30 in midnight.
No, 1:30 p.m. in the afternoon.
Okay, 1:30 p.m.
You 3.5 hours ahead of us.
Okay. So, sir, you are settled there since you're born brought up there, or you are settled migrated from here?
No, I was born here. My father was born here too. So we actually third generation.
Oh.
Yeah, I'm actually third generation now.
Okay.
But I studied because in those days when I actually went to university, it was mainly for white people.
Mm-hmm.
So I came to India to study, and I did my medical studies at King George Medical College in Lucknow.
Oh. Mm-hmm.
But I did my interscience at Bhavan's College in Andheri.
Mm-hmm.
So I have very fond memories of my life there.
So can we initiate the discussion?
Yeah, I can.
Yeah. So anybody has any specific question or any point which needs to be discussed urgently? Any difficult case or anything is otherwise we will proceed for as decided on progesterone. Hello.
Hello, sir. Am I audible?
Yes, you're audible. Yes.
Yes, sir. Sir, my question was that we find a number of patients for either IUI cycles or normal, for infertility, that they don't respond by sub 150 IU of HMG. Also, there were 2 or 3 patients we kept on giving after 75. We started with 150 HMG and then 6 injections. And she was not PC also, and all her hormonal parameters were normal, but the FC was, sir, around 12. So 5-6 follicles this side, 6-7 follicles this side, and then also nothing happened. So what could be done more for these patients?
Rest of the people, if you can mute yourself, then it will be better because some disturbances from the background is coming. Please. Yeah. So the points remain same. There are specific cases which needs a higher gonadotropin consumption, and those are very specific type of patients. One of them is CC resistant PCOS, or you can say phenotypic A and B PCOS, or you can say the PCOS having AMH more than 8, 9, or you can say so these PCOS have a raised basal LH level. So these are the PCOS which needs a higher dose first. Second, it is related to the obesity. The obese patient requires higher dose. 3. The patient of adenomyosis, endometriosis, or any peritoneal disorder like fibroid, polyp, chocolate cyst, endometriosis, chronic PID. So these are the patient who needs a higher dose of gonadotropin. Apart from that, uh, the patient who are having a diminished ovarian reserve, because diminished ovarian reserve patient, they have left the oocytes which are having a lesser number of FSH receptors and having higher FSH threshold. So they needs a little higher dose of gonadotropin. So these are the normal causes of higher gonadotropin consumption even in non-IVF cycle. Apart from this, of course, if anything wrong with the receptor polymorphism, those patients are also likely to respond in that way. And most common cause, the most common cause
Yes, sir.
I'm really sorry. Really sorry. Okay. So the most common cause is practical is the inefficacious molecule that we are using
Okay.
is not giving proper what you call bioavailability, and there is some problem in the quality of the molecule. So these are the likely cause of higher consumption of the gonadotropin. Now, what is
Okay.
ideal? More normally, most of the patients they do well up till 150.
Yes, sir. Yes.
If you really want to avoid a multi-fetal pregnancy, the average dose is approximately 112.5 unit, and more than that is required. Before judging that this gonadotropin dose is insufficient, you need to give for at least 4 days. And on 5th day, if you do not find any follicle which has crossed 10 millimeter, then you can consider that it is still the FSH threshold is not crossed. So these are the common reason for higher gonadotropin starting dose or consumption. So ultimately, there is no thumb rule. Okay, for
Not
non-IVF
high.
cycle, you cannot cross 150, you cannot cross 200, you cannot cross 220. Ultimately, unless you cross the FSH threshold of the follicle is not going to be recruited. So that's the possible reason. Nothing else.
Okay, so if the patient is like not willing for her, like once we can say that we will take out your follicles, and she says, no, I don't have the money. So should we increase the dose after 150, like after taking out all the other factors, or should we try her in the next cycle? Can we cross the 150 dose, sir?
Sorry. It was not audible to me. Please repeat. Please repeat.
Yes, sir. Yes, sir. Thank you, sir. Sir, I was asking when we have ruled out all these factors, and or maybe like we have this patient with us, and then we know that she will not get an OPU done, and like the only thing might go into emphasis. So can we go above 150 also in non-IVF cycle?
Why not? Why not? If the cost is not a restriction, prohibiting
Yes, sir.
factor, you can definitely. There is no. I said no, there is no thumb rule. Okay, you cannot go beyond 150. No, it's not a rule.
Okay, so we can even go for
300
220.
also. Why not? Why not? You have to cross the FSH threshold. Then and then the follicle will start recruiting.
Okay, so it's not that once we give 300, the risk of OHSS will be there because we are watching her every day.
Why should we risk? See, ultimately, OHS's risk is not directly related to the gonadotropin consumption. It is
Yes, sir.
related to related
Absolutely.
primarily to the number of the recruited follicle, and second to the peak E2 level.
Okay, sir. Yes, sir.
Yeah.
So we keep a watch, and then we can go even up to 300.
Absolutely.
Okay, sir. Thanks a lot, sir. Thank you.
Yeah.
So we get the E2 levels done also, sir, na? Once we are having a 300 dose for the patient.
See, I go by the number of the follicles. If the number of the follicles are not that great, then we did not go. See, so before the OHS says, you always get some clue, like patient having a lot of, I mean, free fluid in the pouch of the glass. The patient will be symptomatic. Some GI symptoms will be there. So if such things suspected, then before giving her trigger, E2 level can be done.
Okay, sir. Okay, sir. Thank you, sir.
Yeah.
Okay.
For a patient with lean PCOD, what is the difference in an IUI cycle for a lean
Sorry?
PCOD and obese PCOD, treatment-wise?
Okay. So I normally in Indian scenario there is no much differentiation in lean PCOS and obese PCOS. The lean PCOS, they have got most of the time raised basal LH levels, so they are resistant, and many times their androgen levels are quite high. As far as the obese PCOS is concerned, they have more of insulin resistance and glucose intolerance. In any case, both the cases, insulin sensitizer is required. So, I think there is no differentiation. Mode of treatment does not change. If it is a lean PCOS, hello, if it is lean PCOS, then your gonadotropin dose may be less to start with, and that is the only difference. Otherwise, there is no such difference.
Okay, sir. So in patients who are not responding with higher doses, can we add steroid even if she is not PCOS from day 2?
You are talking about non-IVF or IVF?
Yes, sir. Non-IVF. Yes, sir.
So non-IVF patient, if the patient is not responding to gonadotropin, steroid might help, might not help. Because if there is a hydrogenemia for some reason, then steroid may be helpful. And second, steroid may be helpful by acting as a growth hormone because it increases the IGF-2 level, and by that it may increase the sensitivity of the gonadotropin, or may you can say it may potentiate the action of gonadotropin. So you can try. I have never tried. I have tried in IVF cycle in poor responder where a patient is not affording for growth hormone or something like that. Then I have tried, and there is a difference seen sometimes, not always. So this is a very simple drug which one should not be hesitant in trying. But you must rule out glucose intolerance. And second thing, acid peptic disease, because it is prone to cause gastritis. So these two things must be ruled out. But
Okay, sir.
definitely you can try. Definitely you can try.
So you said glucose intolerance. If she has glucose intolerance, then also we will not give her
Steroid.
Dextrona tablet.
Obviously, steroid will not be because it will increase the. Suppose the patient is on a diabetic drug, then it may increase the sugar level.
Okay, so we can do this insulin sensitivity test also for her, sir, HOMA IR and all.
Yeah.
Okay.
Nowadays we do HB1AC. That's a simple.
Yes.
That gives idea about the average level.
Okay, so HbA1c. That's a very simple and good test. Yes, sir. Okay, yeah. Thank you. And sir, the dose will be Dextrona tablet, 2 milligram.
2 milligram.
OD, sir.
OD, 2 milligram OD.
From day 2 till the day of trigger.
Ovulation. Yeah.
Okay. Thank you. Thank you so much, sir.
Okay.
Good evening, sir. I actually wanted to know about the use of intrauterine HCG, the indications and how to prepare it and when to give it. And secondly, my question is there something as too much progesterone also in luteal phase support? And will it hamper the window of implantation? Because I have a patient with ERA receptive on some hours of progesterone, and I did her serum progesterone before transfer, and it was 45. I did the transfer anyways, but I just wanted to know whether there's something as too much progesterone which can hamper the receptivity. The receptivity is already confirmed on ERA.
Yeah. So first question was regarding
Intrauterine HCG.
Intrauterine HCG.
Yeah.
The idea of role of HCG in luteal phase came from the finding. Please mute yourself. Rest of the people, please mute yourself. Because they found LHCG receptor in the endometrium during luteal phase, upregulated. So they got idea that there has to be some role of LHCG receptor in the luteal phase. So they kept trying. And as far as the intrauterine HCG is concerned, if you go by the evidence, you find both contradictory result. One paper said that if you do intrauterine HCG, it competes with the hyperglycosylated HCG, which is a first HCG secreted from cytotrophoblast of the chorionic villi. So they say it competes, and this hyperglycosylated HCG is more important for placental differentiation, chorionic villi differentiation, and initial establishment implantation of the pregnancy. So if you give external source HCG, then it competes with it and it hampers the result. Same time, another study said that if you give intrauterine HCG, because there is a role of HCG receptor in the luteal phase, it increases the implantation rate. The very recent, the latest, I would say, not very recent, but the latest study and meta-analysis on using intrauterine HCG says that intrauterine HCG is useful only and only there is more than two implantation failure. That is what has been proved in their study. It is not useful routinely. It is not useful for one failure. It is useful if there is a persistent failure. And in such case, if you use an intrauterine HCG, then it was found to be useful. So I am following that reason. When there is a failure more than two times, well, I mean two times, third time, definitely I am incorporating intrauterine HCG before the transfer. So if I have to use HCG, I am just trying using HCG in a two-way. One, giving HCG subcutaneous or intramuscular. Please. Dr. Jay Gopal Sharma, please mute yourself. Dr. Sharma, please mute yourself.
heartbeat का जो rate है normally जैसे 120 plus होता है 122 160
Dr. Bhavna
95 आ रहा है
please mute yourself.
Initially मैं कई बार
Dr. Bhavna Agrawal please mute yourself. Okay, so I am trying in a two-way. One, I give HCG injection 36 hours before starting my progesterone, even in the FET cycle. I tried in two cases and both the patient became pregnant. I don't know what was the reason, whether it is related to that or not, but this is fact. I gave HCG 36 hours before the starting progesterone. That is one way. And more frequently, I have tried intrauterine HCG. Now, how to use intrauterine HCG? So any HCG ampule which you are using, urinary HCG, probably if you can use recombinant, it is still more better. So you take a HCG syringe, HCG in a syringe, and insulin syringe, I would say, so that you can perfectly calibrate if you want to introduce 500 units intrauterine, uh, what amount of units needs to be pushed inside. Say, for example, 1 ml is 5,000 unit. 1 ml is 5,000 unit. So if the insulin syringe is having 100 units, then 1 unit of insulin syringe is 50 units. So I need to push 10 units of insulin syringe intrauterine if I want to use 500 units of HCG, and doses is 500 unit. So I take 1 ml HCG 5000 in the insulin syringe and take IUI catheter, fill the IUI catheter and fully with the HCG injection, then introduce gently from the cervix into the uterine cavity, let it cross the internal os and go 1.5 centimeter beyond that, maybe mid cavity, and push 10 units of insulin syringe so that will deliver 500 units of HCG in the uterus. This is to be done 10 minutes before your actual transfer. So if you wait for 10 minutes, you will find that the liquid which was there in the endometrial cavity little bit that gets absorbed or dispersed, whatever you can say, but it is no more visible. But it has to be done very gently, and you should avoid scratching endometrium as far as possible. It has to be done very gently. And if you think that you are finding difficulty, then better to just cross internal os and push the HCG. So this was about the using intrauterine HCG. Now coming to your second question, uh, how much is too much progesterone? So this is a very tricky question, I would say, because the literature is not very clear. Literature is clear what should be the bare minimum serum progesterone level uh, before starting the progesterone, before transfer, during luteal phase, bare minimum level, where the pregnancy rate, implantation rate is optimum. But literature is not clear what is upper limit of progesterone level. I could find out only one study which say that instead of, especially in FET cycle, instead of 600 IU of micronized vaginal progesterone, if you make it 1200, it will increase the implantation rate, pregnancy rate. That is only a one study. But logically, I strongly believe that nothing more, nothing is better. I mean, nothing in excess is good for the result. So, what are these the optimum levels? So, before starting progesterone, I believe that the progesterone level should be less than one or less than one. At the most 1.1. Many of the studies, many of the people, they say 1.5. No, I don't agree. It is 1.1 or at the most 1. So it should be less than 1. If it is a HRT cycle or down-regulated HRT cycle, most of the time the progesterone level is even less than 0.5, 0.1, 0.2, even less than 0.1. But you should not worry, because you carry that notion, or you might have heard somewhere that progesterone level too less is also not good. Mind you, this that is progesterone level less than zero point 0.5 is not good for oocyte, is restricted to a stimulation cycle. It is not related to the FET cycle. So progesterone level should be less than 1. That is one thing before starting progesterone. Now, if you start the progesterone and after 3 to 4 days of progesterone by whatever route, if you're measuring serum progesterone level and that progesterone level is between 10 and 20, that's good enough. After 3 to 4 days of starting progesterone. Now, same is before ET. It should be between 10 and 30. What about the luteal phase? Luteal phase also, it should be between 17 to 30. That should give you a optimum pregnancy rate. Now, what about the higher dose of progesterone? A very limited people, they believe that higher there is no problem. Whatever progesterone you can, if you want to give, you can give. I do not agree totally with that, but there are certain logical beliefs which you must also agree with that. Whatever we do in FET cycle, we try to mimic the pattern, hormonal pattern, which happens in the natural cycle. So, what is the pattern of progesterone in natural cycle? Now, if you look at the natural cycle, the progesterone start rising before LS surge. When the estrogen is at peak, more than 200 picogram remains for 50 hours, then the progesterone start rising. And after the rise of progesterone, LH surge happens. And when the LH surge is in the downfall, the progesterone level increases tremendously. I mean, the majorly increases at the down peak of the down curve of the LS surge. And then the further rise happens only after ovulation. So major rise occurs after ovulation. That is once that corpus luteum is formed. So luteinization initiate progesterone production, but it is restricted. If you measure the serum progesterone level, the serum progesterone level is always less than 2 before LS surge. Once the LS surge has happened, and if you measure the progesterone level 8 hours after the LS surge has happened, it is in the range of approximately 3 to 6 nanogram. And once the ovulation has occurred, then it crosses 9.5, approximately 9 nanogram. So, whenever you are measuring progesterone level, and if it is more than 9 nanogram, that means your the window of implantation is already closed and you cannot transfer in that particular cycle. So after that, it keep rising and it remains between 20 nanogram. So this is about the natural cycle. The natural cycle, corpus luteum secrete 25 to 50 milligram of progesterone daily. So that is good enough progesterone. And now a lot of studies they have come up that the natural cycle transfer is good for recurrent implantation failure. Natural cycles transfer reduces the perinatal problem, modified natural or natural cycle. So more and more people are relying, and more evidence. Please, uh, Dr. Indu and Dr. Sambiran Ran, please mute yourself. Some background noise is coming. So more and more people they are shifting to a stimulated or modified natural cycle. because they want to take the advantage of the corpus luteum. And we know that when you are doing a modified natural cycle or stimulated cycle, you do not tend to provide a very vigorous luteal support. For example, if you are doing a natural cycle or modified natural cycle where you're given SCG trigger and patient has ovulated, you need not start progesterone for next 3 days after your SCG trigger, provided you have documented ovulation. So the requirement of the progesterone for the successful implantation is not that great. It's not that great. Now the question comes in IVF. Uh, I'm sure, Dr. Rajeshri, are you listening? No?
Yes, sir.
Yeah. Yeah. So now the question comes in IVF. In IVF, we get a lot of patients of PCOS. We get a lot of patients of endometriosis. We get a lot of patients with the peritoneal disorders, where they actually, because of the inflammatory cytokines, there is a progesterone resistance. So we need to give a higher dose of progesterone. And that is the reason why we are providing additional support of the progesterone. Now, in my practice, my standard luteal support is nowadays I give aqueous progesterone for 5 days. I start letrogesterone 1 TDS together from the 0 hours, and after 5 days, on fifth day, I change over to vaginal macronized progesterone and letrogesterone to be continued. So after 5 days, patient is only taking letrogesterone and vaginal progesterone. And initial 5 days, patient is taking letrogesterone and macronized vaginal progesterone. Couple of times I measured progesterone level, and I always found progesterone level less than 40. So then I stopped measuring a serum progesterone level. Now without measuring only, I keep doing without compromising the result. Now the second question is what is the difference uh, in vaginal macronized progesterone? What is uh, what is more useful? Serum level coordination is more useful, or dosage is more useful? I mean, prognostic side, I would say. So I went through a literature in detail, and I concluded from the literature, not my conclusion, from the literature, that the immunomodulatory effect and anti-inflammatory effect of progesterone is directly related to the serum level of the progesterone. So when you get such cases where inflammatory cytokines are more, you should be little more cautious not to give less progesterone, not to have a lower serum level, but you can have a little higher serum level of progesterone. Because the uh, the receptors, or you can say gene expression, which are responsible for implantation, only 30% are the estrogen is responsible. In 60% of the genes are progesterone is responsible. So progesterone is a primary hormone which changes the game and making the environment ready for the embryo to implant. So immunomodulation and anti-inflammatory effect is better when serum level is higher. Now, what happens if you keep the serum level higher right from the beginning? So what happens if you have a given a very optimum dose of estradiol, say 2 milligram BD maximum. And endometrium is ready. So in such patients, suppose if you uh, give a higher dose of progesterone, uh, probably does not make much difference. But the patient where unnecessarily you have used very high dose of estradiol, 12 milligram in a day or 16 milligram in a day or 18 milligram in a day, where estrogen does not only proliferate the endometrium, but it induces the progesterone receptor. So there is a more induction of the progesterone receptor. And the moment that endometrium is exposed to the progesterone, slightest progesterone, there is a massive transformation, a secretory transformation. And theoretically, it can change the window of implantation. It can advance the endometrium further. All the advantages of frozen embryo cycle is gone. They are gone. Why we are not transferring fresh? Because we do not want a supraphysiological high level of estrogenized endometrium. We do not, that's the primary reason. And here in FET, if you are doing the same thing, exposing the endometrium to the very high dose of estrogen, you are losing all the advantages of frozen embryo transfer cycle. So, in nutshell, I strongly believe that the progesterone exposure to the endometrium should be gradual. For initial 2 days, it should be a little lesser. And then whatever amount of progesterone, if you want to give, you can give. And the maximum exposure should be around implantation time. That is maybe 5 to 8 days of your progesterone exposure, starting progesterone, because that's a time of implantation. Because implantation window opens up after 2 days of progesterone exposure and remains open for next 4 days. So 6 7 days you can say after 2 days. After 2 days first 2 days should be a lower amount of progesterone, and next 5 days should be a higher amount of progesterone. But Dr. Rajasri, there are not adequate evidence what is the highest level acceptable. Somewhere I read even if it is 100 nanogram, it does not affect the implantation. But I am a believer of that group that too much is bad. So you should be very judicious in giving progesterone. Once we are using dydrogesterone, we are not much worried about the anti-inflammatory and immunomodulatory effect. So now, what are the disadvantages of vaginal progesterone? That's very important. If you are using very high dose of vaginal progesterone, first of all, if you please mute yourself, Dr. Nina, Dr. Mamta, please mute yourself. So if you are using a very high dose of progesterone, vaginal progesterone, what happens? The endometrial level is achieved very, very quickly. Within 2 to 3 hours, it is achieved. But serum level is not that great as compared to the intramuscular progesterone. Now, so that if that endometrium is hyperestrogenized, I would say, then there is a rapid secretory transformation. And sometimes in some of the study, they have suggested that if you are using exclusive vaginal progesterone to start with, actually your progesterone exposure should be lesser than the embryonic age. Means if you are transferring 72 hours embryo, your progesterone exposure should be 60 hours, for example, maybe 48 hours. Of course, I do not follow that, but this is one of the study. They say recommendation is if you are using exclusive vaginal progesterone, your exposure should be less. So the crux is vaginal progesterone quickly transforms proliferatory endometrium into secretory endometrium. That is one problem with the exclusive vaginal progesterone. Now, if you are using excessive dose of vaginal progesterone, as per one study, it increases the endometrial contraction. Vaginal progesterone, micronized progesterone, increases the endometrial contraction. So it is making the endometrium more irritable. So I am strongly against using higher dose of vaginal progesterone right from the beginning. Rather than, I am of opinion that in the initial part of the progesterone, the steady level is more important rather than endometrial level. Is that okay, Dr. Rajasri? Dr. Rajasri, the query is solved?
Yeah, one thing you said that if we are giving too much of estrogen, the city change happens very quickly. So we should decrease the progesterone in those circumstances. That means if we are using estradiol in a very high dose for patients, then we should stick to a little lesser dose of progesterone instead of increasing it.
That entirely depends on, again, another thing comes into picture. What happens? The difficult cases are endometriosis and PCOS because there the expression of aromatase enzyme is also more. Aromatase enzyme expression is more, and same time progesterone resistance is there. So it's a little tricky situation. So if you want to make a rule a uniform, because what happens as per the study, very little progesterone is required for secretory transformation. This sentence you should remember lifetime. Very small amount of progesterone is required for secretory transformation, and higher dose of progesterone is required at the time of implantation. So you have to maintain these two rules. So by uniformly, you can always adapt a what you call working, that you start always with the smaller dose of progesterone at least for 1 day or 2 days, then add additional progesterone and maintain that till the implantation is over, and then cut off this injectable progesterone and change over to vaginal progesterone. That's the balance situation.
Okay. Okay, sir. Thank you so much.
Yeah. Any other query?
Sir, do you give prednisolone or HCG for immunomodulation for RIF patients?
SCQ I have never used, and I really do not have adequate knowledge on that. And I have not come across a very reliable study on SCQ. So really, I do not know. But then I have listened. I mean, a couple of people, they were telling about the success after giving SCQ. I'm not sure. I have not used, never used. But prednisolone, I have used in few cases, especially when there was a uh, chemical pregnancy repeatedly or miscarriage. So, as suspecting some sort of thrombophilia or maybe some natural killer cell problem, empirically, I have used prednisolone, but not regularly. Why I do not like to use steroid in transfer cycle is because I understand that implantation is the balance between pro-inflammatory and anti-inflammatory cytokines. It's a balance, Th1 and Th2 response. So Th1 is pro-inflammatory, Th2 is anti-inflammatory. So when the embryo blastocyst comes in contact with uh, the endometrium, there is need of pro-inflammatory cytokines, Th1 prominent, IL-6 and other. Yeah, so that type of cytokines. But once these periods last for approximately maybe 4 to 5 days, and after that, further to prevent the further invasion dip, and to have the immunotolerance, the role of Th2 predominance comes into the picture, where anti-inflammatory cytokines should be more. So I really do not know up till what time there is a role of pro-inflammatory, and after that, when the anti-inflammatory cytokines are to be understood. So wherever I have used, and second thing, the studies which I read about using prednisolone, none of the study they have identical dosage schedule. The the study which has clearly shown the benefits of prednisolone, they have used very high dose of prednisolone, 40 milligram. They use 40 milligram daily dose of prednisolone, which I do not want to use. Some of other study they have used 5 milligram. Some of them they have used 10 milligram. So what I have done so far, whatever cases, whichever cases I use uh, prednisolone, I start during uh, estrogenic phase, proliferative phase, and stop as soon as I start progesterone, and I start again prednisolone after 6 days. So approximately 1 week gap I always keep to cover the implantation window, because I am assuming that at the time if I give prednisolone, it will change the ratio of Th1 to Th2. So, but since we are not a research institute, we have to keep trying based on our endocrinology knowledge or logic, whatever you say. And number of the cases are not that great that I can say, okay, I tried in 50 cases and this is the result. No, very, you can count on the finger that many cases we have tried. And impression uh, is not helping much. That's my impression.
Okay,
Sir,
sir,
good evening,
thank you.
sir. This is Kavita.
Yes. Good.
Sir, your take on colony stimulating factor in IUI cycles, especially the unexplained infertility or repeated IUI failures, have you used, sir? What's your
IVF.
take on that?
Yeah, you are talking about IVF failure. IVF failure.
No,
Repeated.
IUI. IVF I use, sir, routinely. IUI.
Now you are talking about IUI. So
IUI.
take on GCSF
Yes, sir. Yes, sir.
in IUI
Because
failure.
I could come across one paper, 2 days after IUI, one shot, pregnancy results are little better. So planning to try and just wanted to know whether you tried.
No, I have tried GCSF in non-IVF cycle only in case of LURF, luteinized unruptured follicle. So where trigger has failed, and next time when I want to do something so the trigger does not fail, I have given GCSF injection 6 hours before the trigger, and in that cycle there was ovulation recorded. So that's the only place where I tried GCSF in non-IVF cycle. But as you read this study, I'm not aware about that study. But then logically, GCSF you can try everywhere, because ultimately it induces the growth factor. It is a basically a growth factor, cytokines, and it initiates. It is always going to be helpful, if not harmful. So you can try, definitely you can try.
Thank you, sir.
Yeah.
Sir, this HCG which you gave intrauterine was how many days before the?
No, 10 minutes, 10 minutes before. Intrauterine is 10 minutes before the actual embryo transfer.
Okay, so in the same sitting, sir.
Absolutely.
Acha, okay, sir. And sir, this steroid that you said, both Visolone and Dexona can be used after embryo transfer?
Dexona we don't use. We use Visolone. If at all, if you want to use, then most of the studies they have used Visolone only, prednisolone only.
Okay, so from the very start, if we use Visolone from day 2,
Yes,
and then
and I normally stop before starting progesterone and
yes,
keep it off for 1 week, and again after 1 week I will start.
okay. So even in IUI cycles, we can start with Visolone only, na sir? Like because it
Yes,
can be
yes,
continued afterwards also if you want.
yes, yes.
Okay, thank you, sir. Thank you.
Yeah.
Sir, good evening. I'm Dr.
Good evening.
Vijaya. Do we
Hello.
need to instill PRP, HCG, everything under ultrasound guidance?
No, 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 no. FCG obviously because you are actually doing in the IVF theater, and it is done just 10 minutes before your actual transfer. So you want to be very sure that then there should not be at all any endometrial scratch. So you should do under ultrasound guidance. Uh, Otherwise, as far as the PRP and GCSF is concerned, uh, we do without ultrasound guidance only.
Okay, sir. Thank you. Sir, yesterday I posted one question. You remember that, sir?
Yeah, please, can you repeat? Can you repeat?
Like that patient is a 31-year-old lady, sir. She is actually, I planned her for modified natural FET. So I called her on day 7 of her cycle, and follicle was 15 millimeters, and ET was 6.9, and it was very good trilaminar. So I called her after day 9, after very next day, like day after that. And ET endometrial thickness was 8 millimeters, but follicle got ruptured, sir. So I didn't know when the follicle got ruptured, so I cancelled the cycle actually. And progesterone was less than 1, sir.
See,
And LH was 28.
So there is
some.
No, it cannot be. Because what happens, how is the graph of LH versus progesterone? Now what happens? The LH, when the LH is going to the peak, there is a little rise in the progesterone. When LH from the peak coming down, there is a further rise of progesterone rise start maybe 8 hours after the peak of the LH. 6 hours you can say, and it remains like that, maybe around 3 nanogram. Once the LH surge is over, 24 hours after, approximately 12 to 24 hours after the LH surge, the progesterone rise in really. So once the progesterone start rising in the range, it is in the range of more than 2 nanogram, and after LH surge, it is in the range of 3 to 6 nanogram, and after ovulation, it is after LH surge is over and ovulation has occurred, it is more than 9 nanogram. It is once it is raised in luteal phase, progesterone never comes down so suddenly. So your progesterone report is not correct. That is what I'm trying to say. Sometimes it happens that the LH level is less and progesterone is high. And that is the reason in empty follicle syndrome, you have to correlate value of LH as well as progesterone. Because if both LH and progesterone are low, then it is a trigger failure. If the LH is high and progesterone level is low, still you cannot conclude that it is a trigger failure. But if the LH level is low and progesterone level is high, there are chances that most of the time it is not a trigger failure. So progesterone is that gives a robust idea about the luteinization. And once the ovulation has occurred, that you have documented in this case, progesterone cannot be less than 9, I tell you. Once the ovulation has occurred and if you measure the progesterone cannot be less than 9.
Okay, sir. Anyway, I cancelled that cycle, sir, actually.
You have to cancel because that is very crucial to know when the ovulation has occurred.
Yes, sir. Okay. Thank you, sir. Thank you.
Yeah.
Excuse me, sir, in this cycle, if we start the progesterone I think once we were told that even if you have not seen the ovulation and you can start 36 hours after the progesterone, whether ovulation has occurred or not.
If ovulation has occurred, and if you have given trigger, I am not in favor of starting progesterone.
Okay, sir.
I said that progesterone can be started if you have not documented ovulation even after 36 hours, 38 hours.
Of the trigger. Okay. And if it has occurred and we don't know when it occurred, then?
Then previous day before, you know where you have given trigger.
Yes, sir.
So that is why I said that before giving trigger, you make sure that the follicle is there. After trigger, you should always call the patient next day.
But I didn't give any trigger in this patient, sir. Actually, follicle got ruptured very prematurely. Because I tracked the last cycle also. Follicle was there till day 12. So this time it got ruptured by day 9 only.
So it is really good habit of testing urinary LH kit. Was the follicle maybe cycle day 10 or follicle which is 14-15 millimeter. Patient should be given at least even if you're monitoring with the ultrasound, the patient should be given LH kit to measure, and they should send you the picture of that LH test, so that at least you know at least okay, LH surge has occurred. So once the LH surge has occurred, you can still if you do not want to cancel the cycle, you can still plan the transfer date. You can decide.
So after LSS, after how many hours we can start progesterone, sir?
No, after LS, once you documented LS surge, then LH surge plus 1 is your estimated ovulation day. Ovulation day.
Okay.
So that is a 0 hours as far as the endometrial age is concerned.
So LS surge is zero, sir?
No, LS surge is -1.
-1. Okay. Okay.
Yes.
So, sir, when the patient gives us a picture of 2 lines in a kit, that means that is the time of LH surge.
Yes, because morning and evening both here you are considering. So roughly you have idea when LH surge occurs, and then obviously you keep calling a patient for follicle monitoring. So if both are coordinating well, then you can plan your cycle. In fact, there are studies, especially non-IVF cycle, in IUI cycle, ultrasonic monitoring versus the monitoring with the LS surge. The IUI absolutely based on LS surge only. And surprisingly, they did not found any difference in the success rate. So urinary LS surge is quite reliable. You can definitely count on them. And as such, we know that implantation window is not that narrow in most of the cases. So Dr. Rajesh, I forgot to tell you, if you are using a very high dose of estrogen, your implantation window also gets narrow. So that's the reason too much high progesterone, too much high estrogen level is not good. Same with the high dose of vaginal progesterone. The implantation window gets narrow. So, what was the point? What we were discussing?
So this LH kit that you said, so she
Yeah,
has to do
LH kit.
morning and
So
evening, sir.
LH kit. So LH kit, if it is a positive, next day uh, you can consider as a day 0 next day, and you can, irrespective of the uh, ovulation, you can uh, start counting and plan your transfer cycle. Of course, before transferring, definitely would like to see the progesterone level. The progesterone level at least should be approximately around 9, should not be less than 9.
Sir, LH kit has to be used twice a day in these cases. Then otherwise, how will you know, sir? Then
It is ideally it should be used twice, morning and evening.
do we get in gynecare, sir, LH kits?
LS kit is freely available. It is costing 25 rupees, 25 rupees.
Okay, sir. Okay. So one more case I want to ask about one more. Today I have done one pickup, sir. She is around 34-year-old lady with decreased ovarian reserve. Follicles were 5 in right ovary and 3 in left ovary, sir. And E2 levels are also very good, 2,500, 2,800. And today I didn't get even a single ovum. And morning I gave dual triggers. Morning I did urine pregnancy test also. It was positive. But LH was 4 only. Just for interest sake, I have done the LH blood LH levels. So it was 4 million.
That was done after how many hours of trigger?
How many hours of triggers? Like 40, around 40 hours.
So LH level is perfectly normal. If it is 4,
Normal.
it is normal. It is normal.
Okay. Yeah, it will
LH
come down.
Yeah, it will come down. No?
So that is normal only, sir?
LH is normal.
Okay, okay. But I didn't get even a single ovum this today morning, sir. I don't know why. I gave decapeptyl and recombinant HCG.
Progesterone can give you answer.
Can I do it now, sir? Progesterone?
You can. See, whenever, if you want to know anything related to trigger, you must measure progesterone, because progesterone is the first hormone that will give idea about the luteinization, and luteinization never happens without action of LH or HCG.
Okay, okay. So, like, we should consider it as empty follicle syndrome, even if if a progesterone is raised. What should we think about this?
See, then maybe a higher dose requires. Suppose progesterone is present. If it is more than 3, you can say. If it is more than 3, so at this point of time, you are expecting progesterone to be more than 9.
Okay.
Because you already didn't pick up. The corpus luteum has already formed.
Yes,
and almost more than 36 or maybe 40 hours are passed after the trigger. So progesterone level has to be more than 9 by this time.
Okay, sir. I'll get it done now.
So if the progesterone level is more than 9, that means luteinization has occurred, but because of some reason, receptor related problem, or maybe higher dose is required, or whatever.
But only 7 AFC was there, so I gave her 300 IU, both recombinant and menopure, sir. Recombinant FSH and menopure.
No, I'm talking about trigger.
No, like gonadotropin's dose, sir.
No, trigger. I'm talking about trigger. So maybe higher dose of trigger is required, whatever.
Okay.
Because
like a higher dose. I gave 0.2 milligrams decapeptyl. So usually we give 0.1 only, no? But I gave 0.2 milligrams decapeptyl and recombinant HCG I gave 250 micrograms.
That is more than enough. I mean, good enough.
Yeah,
what is BMI of the patient?
BMI, she is a very thin patient, like she is around 40, 42 kgs only. BMI is below 26 only, sir.
Because interestingly, the SCG dosage varies with the obesity, BMI, but the agonist dose does not differ. Agonist dose does not differ with the BMI. Agonist dose remains the same in trigger, but the
Yeah.
SCG dose differs. That is one thing. Second thing, post trigger, whether it is a progesterone level or LH level or beta SCG, they are proportionately lesser in obese patient because of the dilutional effect. This you should not forget. If it is a patient thin lean, then you tend to get little higher serum level. And if the patient is obese, then post trigger, whatever hormonal estimation you do, you get little dilutional because of the dilutional effect, the lesser level.
Okay, sir. Thank you, sir.
Sir, this LH kit should be done for all the patients or some particular patients?
See, it is inexpensive. LH kit is very inexpensive.
Yes, sir.
There are some basic manufacturer, like I know one of them is Biotrol करके एक दिल्ली में company है. Once upon a time, I purchased LH kit in just 10 rupees or 12 rupees maximum.
Okay.
And now I'm purchasing somewhere around 22 rupees a kit. So whether it is IUI cycle or stimulated or natural FET cycle,
Okay.
it is always once up to cycle from cycle day 10 uh, beyond, especially when follicle has been recruited. Always keep telling patient to do urinary LH kit so that in unforeseen circumstances, it helps in correlation.
Okay. So this, sir, the vendor which you were telling us were giving now, can we contact and like one kit was for 20?
Biotrol, suppose if I purchase from Biotrol, they
Yes.
insist that we should buy 1,000 kits at a time because they are manufacturer. Na?
Yes, sir. Acha, acha. Yes.
So 1,000 kit, my at least 200 kit went into expiry.
Yes, sir. Yes.
So now I purchase in small quantity only.
Yes, sir. Okay. So it's good enough. It's not very costly anyway, sir. Okay. So, so like you said, there are some people who do IUIs only according to the LH kit. So, and they
Yes,
have good
yes.
certificates.
Absolutely.
Okay, okay. So once she tells us it is positive, and then we call her for ovulation study, and we watch the follicle. And it can be done that
So
we
if
don't
you
do.
want to do IUI, you
Yes,
have
sir.
to do IUI once you have reported LS surge.
Yes.
Next day, maybe afternoon or evening, you should do IUI.
Okay, so right in 20.
Where you really have limited resources and ultrasound monitoring is not available, you can do
Yes.
IUI.
Okay, so the very next day, sir.
Even next day.
So if she gives
Because
us a report,
once LS surge is occurred,
yes, sir.
the ovulation is expected in 24 to 48 hours.
Okay. So okay, either we do it next day, that is 24 hours. We will be
So
on the
normally
time.
suppose morning we have done LS surge is positive. So
Yes,
you
sir.
can always do after 24. IUI you can do after 24 hours.
Okay.
Yeah.
And even if, sir, it is after 48 hours, you said, then also the sperm will wait for the egg.
Yeah. So IUI, because I discussed that in one of the recent conference, that monitoring in IUI cycle and is not that critical. and one should not be too fussy about the timing of the IUI, because lot of studies they have shown they have clearly uh, shown that even if you do IUI along with the trigger, does not compromise. If you do IUI 12 hours after the trigger, no problem. If you do IUI between after 24 hours, no problem. If you do IUI 32 to 32, 42, anytime, 32 hours to 40 hours, no problem. So, because the basic question we do not know that capacitated sperm after injecting in the endometrial cavity retains the fertilizing capacity for how many hours? There is no study, and nobody is giving clear answer. Even I try to find out from literature, nowhere it is written that capacitated sperm in vivo retains the fertilizing capacity for how many hours.
Okay, sir.
But I'm sure that it is much more than what we think. The sperm retains the fertilizing capacity much longer than what we think.
Acha. We are told that it is 12 hours, but it
No,
is more.
it is more than that.
Okay, sir. And sir, some people think that if I do
Dr. Sai, एक मिनट, Dr. Rekha, let this finish. Dr. Sai.
Yes.
Sir, good evening, sir.
Good evening.
Sir, you told that if you want to give subcutaneous HCG 36 hours before embryo transfer, what is the dose, sir?
Standard dose 5,000.
5,000. Sir, then in thin endometrium, sir, can we use letrozole and tamoxifen simultaneously in the same cycle?
Yes, why not? Why not? Because see, now you have to decide. Because letrozole also have positive effect on endometrium with some different way, and tamoxifen has just proliferative effect on the endometrium. Tamoxifen has got proliferative effect on the endometrium, whereas the letrozole acts on the gene expression which are responsible for implantation primarily. That's the purpose of using letrozole in HRT cycle. Now, if you're thinking that you want to use tamoxifen and letrozole for stimulated FET cycle, then also you are free. I have done that. You can use that combination of letrozole and tamoxifen and do not give estradiol. Definitely there will be recruitment of the follicle, and then you can go according as a stimulated FET cycle. So very well it can be combined even in HRT cycle, or it can be combined in a stimulated cycle.
What can be the dose, sir, if you are combining both?
This tamoxifen is 40 milligram in a day, 20 milligram BD, and letrozole I have used only 2.5 milligram because if I am using as a stimulated cycle, then if the patient is obese or something, I may use 2.5 milligram BD. But normally, I want a positive effect of letrozole, but at the same time, I do not want to recruit the follicle. So simultaneously, I start estradiol along with that.
Estradiol, we start with 2 milligram BD.
After 5 days, 2 milligram BD.
Yeah, so first 5 days we give letrozole and tamoxifen. After 5 days we give estradiol.
Yes.
Okay, sir. Sir, ATT, ATT we are using, no, sir. Will we use only 2 drugs, sir? Isoniazid and ATT. You told that empirical ATT can be used. If endometritis cases like that, if we are using that.
The AKT4 standard I use AKT4.
ATT4. Okay, sir. And prednisolone, you told that 6 days after embryo transfer, we can start prednisolone if we are using it. And up till how many days can we use that, sir?
But it can be stopped once cardiac activity, heart activity appears.
Yes,
Because
sir.
you are using here you have started empirically.
Yes,
So
sir.
till the cardiac activity.
Yes, sir. Thank you so much,
Yeah.
sir.
Yeah. Dr. Rekha, you were talking something?
Sir, I was just asking that question that some people say that our IUI results are better if we do post ovulation when we have seen the ovulation. Does it have any?
No, 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 no. No, not at all. Not at all. Not at all. In fact, in fact, I strongly
Yes.
believe that the sperm should be ready to welcome eggs at the ostia. That's the ideal situation. That's the ideal situation.
Okay, sir.
Sperm
And you've
should be
given a
already present.
number of,
Yeah.
you are saying either you can even do at the time of
See, if you
trigger, 12 hours after trigger.
by looking at the various study, combining it to my own experience, and combining logic, combining the conclusions, uh, I'm sure that
Yes.
suppose if you give trigger today, call the patient after 24 hours and do IUI.
Okay, sir. Okay.
And if you want to do a second IUI, call again patient after maybe 42 hours of trigger and do second IUI. If you want to do two IUI. Otherwise, if you want to do single IUI, do after 24 hours. If you want to still want to be precise, more precise, then
Yes.
look at the vascularity and PSV value of the perifollicular flow and
Yes, sir.
accordingly decide. If it is, say, more than 20, then only do single IUI 12 hours after your trigger. And
Okay.
if it is more than 10, then after 24 hours, single IUI.
Okay.
And if you want to do double IUI, then first IUI after 12 hours and second IUI after 40 hours. But I normally do single IUI. I do after 24 hours, 24, 28 hours, depending on the availability of the embryologist. So I'm not too fussy about the timing of the IUI because I have never seen that great results of IUI. So
Yes, sir. Yes, sir.
yeah, and never read the great results of IUI. So IUI, if it is to be succeeded, anyhow, it can be succeeded whatever time you give. So I give normally after 20, do IUI after 24 hours of the trigger.
Okay, sir. And some people are saying 36 to 40 hours after trigger. That is also all right, sir?
So most of the people they believe that it should be done 36 to 40 hours. My caveat, my objection is you never know. You are hiding 36 to 40 hours is good, provided you have used antagonist in that cycle. It is good provided you have done hormonal assessment. It is ideal if you are knowing that at the time of giving trigger there was no LS surge.
Oh,
So
okay.
because in IUI cycle, the chances of premature LS surge is approximately 25 to 30%.
Yes, sir. Okay.
So if you are doing proper hormonal monitoring, maybe with the urinary LS kit, and if you're sure that LS surge has not occurred when you gave the trigger, then I would prefer to do IUI after 36 hours only.
Okay, sir. Okay, so because of the LH surge, you do it after 24 hours when you have not measured the hormone.
Yeah.
Okay, sir. Okay, sir. Thanks a lot, sir.
Yeah.
So the results, sir, do you make it like? Do you find it they are more than 30%, sir? 20 to 30%?
Whatever. No. I have never got 30% result in IUI. Never.
Sir, for us, I think it is only 15% or 20, not more than that.
So if somebody from our group who is getting more than 20% result, I would like to learn the tricks how to increase the IUI success.
Yes, sir, exactly.
Because some people have told us that my results are round about 60 to 70%. So
It's not
very
possible.
confused.
No, it's not possible. They should probably publish that paper. Why they are not publishing the paper?
Okay, sir. I've heard
If somebody proves that they are getting 60% result, I will leave practice. It's not possible. 60% IOI result never possible.
It maybe, sir, very less cycles or whatever, sir. I got very confused when I heard them, but they said that we are getting okay.
No.
Okay.
Dr. Surjit.
Good evening, sir.
Good evening.
I just want to ask, sir, ATT4 you have said for 3 months only we have to give?
No, normally I try to give for 6 months, but after 3 months I start stimulating her. Whatever for control over stimulation for maybe IUI time intercourse or maybe IVF, whatever. So after 3 months I start stimulation.
Reduce the dose ATT for you come to 3.
Yeah, then I make it AKT3 instead of AKT4, AKT3. So 2 drugs.
After 3 months, huh?
Yeah, after 3 months.
Sir, next question is a progesterone level on the day of embryo transfer. It should not be more than 30, sir.
See, if it is more than 30, that should not be a reason to cancel the cycle. No. Cancellation of the cycle should be done if the progesterone level is less, not because it is more. See, if level is more, you can reduce the dose of progesterone support, but you should not cancel the cycle unless it is more than 100, something like that.
Thank you, sir.
Yeah.
Sir, if we are giving empirically ATT and we want to do FET, then how many months we should continue ATT?
See, I know
empirically
if AKT was given empirically, and after 3 months we start the regular treatment in whatever way we have decided, and if the patient becomes pregnant, the moment the urine test is positive, pregnancy is confirmed, we stop AKT.
Okay, thank you, sir. And sir, instead of doing LH kit, can we do serum level of LH? And sometimes it happens that LH kit is not giving the nice results, and there is a progesterone rise, and we cannot do FET cycle, natural modified cycle.
No, see, LS surge itself, to decide LS surge is very complicated. It's very complicated. Unless you combine the result of LH with the progesterone, really difficult to estrogen. So suppose if you want to rely on serum levels to decide LS surge, you have to do daily LH and estradiol. Then you can decide the perfect LS surge, because there is a various definition. Some believes the most standard belief about the LS surge is the LH should rise previous 3 days average 180% above minimum of the previous 3 days average. The level should be more than 17. And the day should be considered when there is a next day fall at least 30% in estradiol level. So what is more important is 30% fall in estradiol level. That is more important. Suppose on Tuesday, LH was 18. On Wednesday, LH was 21. On Tuesday, on Tuesday when LH was 18 or 19, whatever, and serum estradiol level, say, for example, was 200. Next day, serum LH level has risen, but the estradiol level has fallen. It is 120 only. So, LH surge is first day, not the second day. even if the LH level is high. So it is very complicated, and it is not really possible to monitor in such a very different definition. If you want to take a single value, the LH level should be more than 20. Uh, uh, Another definition, the LH level should be at least 2.5 times than the average follicular level. So now, to take the average follicular level, follicular phase LH level, really, who measure LH level daily to decide 2.5 times? So it's not possible. So the practical solution is, before giving HCG, you take a blood sample, and if that serum LH level is less than 17, you consider that LH surge has not occurred. And call next day, follicle has not ruptured, that means LH surge has not occurred. You got it?
Yes, sir. So in this case, we will not give HCG. You are saying that before giving trigger, we will do LH and progesterone. And if
But
the
then
LH...
No, I never said.
Okay.
Before giving trigger, measure LH and progesterone and give trigger. Because it is now, although little contradictory, but now more studies are coming up that even after occurring LS surge, if you give a trigger, it does not harm. In fact, according to some study, it increases the pregnancy rates. So you should not worry if you are riding on LS surge. So trigger should be given, but you must know whether you are riding on the LS surge or not. Because if you are riding on LS surge, then you are likely to ovulate next day. And if you are not riding on LS surge, C is likely to ovulate 36 to 38 hours after your trigger. So your timing of IUI, your timing of FET, considering 0 hours, varies with the LS surge LH value.
Okay. If the next day there is rupture, we will start progesterone from that point.
No, I never said start progesterone. I said 0 hours endometrial age is started. I never believe starting progesterone immediately.
Okay. But we will count it as a 0 hour.
0 hours.
And progesterone after 36 or 40 hours of HCG.
Yes.
Okay. Thank you.
Absolutely. So this is the biggest mistake most of the people make. They are very prompt in starting progesterone. See, once the ovulation has occurred, keep relaxed. Progesterone is there. If you are in doubt, measure progesterone. Once the ovulation has occurred, progesterone is bound to be more than 9. So don't worry about your progesterone.
And how much dose you will start after 36 hours of HCG of progesterone?
See, if that depends whether it is which cycle. For example, it is a stimulated cycle, and the follicle has been ruptured. Then I will start with the dydrogesterone and macronized progesterone 200 milligrams 3 times a day within 72 hours of my trigger.
72 hours after trigger.
Of my trigger.
Okay, sir. Both together.
Yeah, together.
Okay. And you will transfer according to
0 hours.
If rupture is not there, sir. Suppose rupture is not there, then you will count 0 hour after 36
from the starting progesterone. Starting progesterone.
Okay.
Starting point of progesterone.
72 hours after HCG, you will count as a 0 hour.
No. If the follicle is not ruptured, I will start progesterone 36 hours after my trigger.
Okay.
38 hours. 36 to 38 hours.
Okay. Thank you, sir. Okay.
Dr. Janani? Dr. Janani, you have raised a hand.
Yes, sir.
Please.
Yes, sir.
Yeah.
I'm Dr. Janani, sir. Good evening, sir.
Good evening.
Sir, I have a doubt. You told that we are supposed to do IUI 24 hours after trigger. Sir, what would be if the follicle is not rupturing, sir? Because I had a case. Because I usually do at 24 hours, sir, before this thing. But I had a patient for whom I did at 24 hours. But later I checked whether the follicle has ruptured the next day. So I called her, but the
follicle rupture is not mandatory. To document ovulation is not mandatory for IVF success.
Okay, sir. But the follicle
because
okay.
Because once you do IUI, the very motile capacitated sperm enters into the uterine cavity, and there is no reliable study which says that this sperm retains the fertilizing capacity for how many hours. Some say 4 hours, some say 12 hours, some say 24 hours. I believe it is more than 24 hours. Why? Because I do not have direct evidence, but I have indirect evidence. What indirect evidence I have? I have study which has concluded that even if you do IUI same time simultaneously with the trigger, success rate is not compromised. I have study which has concluded that if you do IUI 12 hours, single IUI 12 hours after your trigger, success rate is not compromised. I have study which has concluded that if you want to do IUI and for some reason the husband is not able to come in time, if you wash the sperm, and the moment you wash the sperm becomes capacitated, that you know, right?
Yes, sir.
So if you keep the washed sperm at room temperature, and if you do IUI within 24 hours, the success rate is not compromised. So I have study which has concluded if you do IUI from 32 to 40 hours anytime, success rate is not compromised. I have studied which says that single IUI at 40 hours is ideal and success rate is not compromised. So really the literature does not conclude what is ideal time of doing IUI. Whether it is at the time of trigger, after 12 hours, after 24 hours, after 32 hours, after 36 hours, after 40 hours, that means all are either correct or all are incorrect.
Okay.
Do you agree?
Yes, sir. Sir, then what about an luteinized unruptured
So
follicle?
now, why I am telling that IUI should be done after 24 hours? Because when I give trigger, I do not know whether I am riding on LSR or not. So if I am riding on LSR, the follicle is going to rupture in next 24 to 48 hours. And if I am not riding on LSR, the follicle is going to rupture after 36 hours of my trigger. So if I do IUI after 24 hours, it is going to, assuming the life fertilizing capacity is 24 hours of the sperm which is introduced in the endometrial cavity. Even if ovulation occurs within 24 hours, after 36 hours, within 48 hours, that IUI is going to cover. So that's the rationale of doing IUI after 24.
Okay, sir. So then in cases of luteinized unruptured follicles, then what should we do, sir? Because we'll not know, sir, whether the follicle is ruptured or not. Because
see, if you really want to confirm luteinized unruptured follicle, then you should do a progesterone level. Because many times, even if the follicle has ruptured, the size of the follicle remains same, just change in the little bit echogenicity. So really, it's difficult to make sure that by looking at the follicle, it is not always possible to document ovulation.
Okay, because I had a patient, sir, for whom I did IUI at 24 hours after Ovitril, recombinant HCG, but she didn't. The follicle was exactly what I saw the previous, meaning before that trigger.
So
On the day.
normally, Dr. Janani, you don't expect follicle to rupture in 24 hours of your
No,
trigger.
sir. After 36 hours, after 40 hours, actually, I did. But it was the same size, exactly the same appearance. So what I did, I just checked her HCG, that UPT, but the UPT line was not there, just to know whether HCG has acted or not. Then what did I do? I just gave HCG 10,000 IU on that day after at 41 hours, 41 or 42 hours. Then again I asked her, I just watched her, but no pain, nothing. Then I asked her to come up 48 hours. Again, it was not ruptured only, sir. Exactly the same size and same appearance. So how should I proceed in such cases?
So it's a case of LURF.
Right? Yes, sir.
So next time you should give either dual trigger
okay.
and give GCSF 6 hours before your trigger.
Okay, okay, sir. Sir, is it helping, sir? GCSF, it will definitely rupture, sir.
So far, in my experience, yes, it gets
okay.
ruptured.
So
Dr.
6 hours.
Dr. Surjit, please mute yourself. Dr. Surjit, please mute yourself. Yes, Dr. Janani, please.
Yes, sir. Sir, 6 hours before trigger, GCSF 300 micrograms subcutaneous.
Subcutaneous. Yes.
Okay.
Yes.
Okay, sir. I'll try, sir. And I have tried agonist, sir, for such cases previously. But whenever I give agonist trigger for these unruptured cases, my results are negative only. I don't know whether because of agonist or not. Meaning with agonist and HCG I have given in IUI cycles.
See, whenever you give agonist trigger in non-IVF cycle,
yes, sir.
Always supplement with the SCG within 72 hours.
Okay. Anyway, I'm giving trigger no, sir. With HCG trigger only, I'm giving agonist no, sir.
Achha, dual trigger. You're giving dual trigger.
Yes, sir. No, sir. I'll give HCG and see if it is not rupturing. Then I'll add agonist after 36 or 40 hours. I'll see whether it is rupturing.
See, once let me tell you. Once you give any kind of trigger,
okay, sir,
the re-triggering is useless unless the first trigger has acted like water. It has no medicine.
Okay,
it is acted like water, and there is no effect on the follicle. There is no luteinization.
Okay,
then and then second trigger makes some sense. Otherwise, the second trigger does not make any sense.
Yes, sir. After checking HCG only, I give the agonist trigger, sir.
No, you should check progesterone. That is what I'm trying to tell. You should rely more on progesterone for action of the trigger.
Oh, progesterone should be, as you said, progesterone should be 9.
Because what happens, the SCG bioavailability, depending on half-life, distribution, pharmacokinetics, there is no very defined way how the level in blood level, SCG level after SCG trigger will follow. But you are sure that if the trigger has acted, the progesterone level should be bare minimum more than this, and this is not going to go down.
Okay, okay, sir.
So that is why you should rely more on progesterone rather than LH level and SCG level.
Okay, it should be more than 6, sir. How much should be the progesterone?
See if the luteinization, it should be more than 3, and for ovulation, it should be more than 6.
Ovulation more than 6. Okay, okay, sir. So, and I have another one case, sir. She's 35-year-old lady.
This is Dr. Jani. This is last case because 6:38 already. I have to go for my consultation.
Oh, sorry, sir. This last case.
Yeah, please go ahead.
Okay,
please go ahead.
Yes, sir. 35-year-old lady for whom we collected around 11 oocytes, sir, out of which 8 M2s, and then 2 got degenerated just while doing ICSI itself. It got meaning it got. They told it it collapsed. So the remaining 6 we injected, sir. In that we formed 4 embryos, out of which on day 3 I told to freeze only 1 embryo, just for the safer side. Remaining 3 we took for blast, and all 3 got cell arrested, sir. So your comment on this, sir?
Because it is, see, blastosis, blastulation is dependent on multiple things.
Okay, sir.
Primarily it is depending on the what you call the quality of the oocytes, handling, ICSI, culture, a lot of things, lab environment, depends on a lot of things. So never solely rely on blast transfer. I always keep telling that in frozen embryo transfer, it is just a number game. 3 or 4 cleavage stage embryo gives equal success like 2 blastocyst transfer. So do not be too much impressed by blastocyst transfer strategy. Cleavage and 3 good cleavage stage embryo, and then now still if you want to be more precise, now trick to the success is selection of good embryo having the best implantation potentials. Now this is only possible either by doing PGS or time lapse. This is the only two way of selecting a good embryo. Now, suppose we do not have any of these two. So we have to follow certain criteria. We have to follow the morphokinetics and we have to follow the morphology. Now, if after 38 hours, after 36 to 38 hours, embryo which has cleaved and become 4 cell after 36 to 38 hours, precisely 37 hours. That embryo morphokinetics should be considered ideal. So you should ideally segregate. After doing ICSI, you should always tell your embryologist to examine after 37 hours. And she should segregate the embryo which has already become 4 cell. So those are having good morphokinetics, and rest of the embryo should be kept separately. Then look at the morphology. Suppose if you want to freeze, at the time, freeze or select the embryo which has got good morphokinetics. Suppose if you want to go for blast, select the embryo which is morphologically good and morphokinetics wise good. Then you are likely to get good blast. Because what happens, the paternal genomic activation happens only after once the embryo crosses 8 cells. That is day 3, third day. So then half of the cases, because of the some defect in the paternal genomic contribution, the embryo gets arrested. Some of the cases, either it is oocyte quality, some of the cases, the culture condition may be faulty. Now, in my lab also, I observed that most of us, we rely, we store the media in the standard refrigerator. Now, you just keep a sensor, a measuring sensor with the monitor externally. And if you observe, the temperature ranges from -1 or 1 to 11 in the freeze. It is never 2 to 8. Ideally, those media and everything should be stored at 2 to 8 degree. But this range is 1 to 11, 12. Sometimes it becomes 12 also. So, our lot of things makes a difference. Lot of things makes a difference. So, culture condition definitely plays a role. So, you have to, even if everything is going smooth, suppose you are getting good results, still you should not leave the habit of measuring pH of the media regularly, calibrating the temperature of the freeze, calibrating the CO2 level regularly. Otherwise, sometimes the mishap keep happening.
No, so the same patient in previous, some other hospital, she has done IVF and all embryos got arrested. They have given a summary. So that is why I thought, okay, day 5, day
maybe
3.
Oocyte quality, maybe oocyte quality.
Okay. So next cycle, I should suggest donor for her, sir.
If it has happened twice, 2 times, then definitely, yeah.
Okay, sir.
Or else, suppose patient is not willing.
Okay.
Then I would give lot of coenzyme, Q10 antioxidant. I would give nutritional support like correction of empirical vitamin D3, folic acid, because folic acid supplementation is many times forgotten, and really it is very much valuable. So I would give folic acid, some androgens, vitamin D,
Vitamin.
and lot of antioxidants. And I will try stimulating after 8 weeks only, 8 to 10 weeks.
Okay, sir. Now my question is, I have a day 3 of that patient, sir. So what should I do with that? Because since other embryos have not reached blast, I'm questioning the viability as well as the genetic content of this embryo. I don't know whether it's a good embryo or not.
So extend little bit, make it, let it go 80 hours.
Sorry, sir, I couldn't.
Let it go 80 hours. Day 3 embryo is up to 48, 72 hours.
Yes, sir.
Now extend up to 80 hours, not beyond that.
Oh, okay, sir. So you want me to extend it and see?
Yeah.
Okay. Okay, sir. Okay. Thank you, sir.
Okay.
Thank you.
So
yes,
I
sir.
take
Thank
your
you so
leave.
much. Yeah.
Thank you.
Yes,
Thank you for
sir.
joining. Yeah, thank you. We'll meet next week. Probably I am busy with some conference somewhere. I'm going to Hubli. So probably next Saturday won't be possible. So next Saturday.